Cancer is a deadly, but also intriguing, disease. In our quest to defeat cancer through decades of medical research, we had discovered a way to harness the power of our own immune system to kill tumor cells, the chimeric antigen receptors, or CARs for short. But since its introduction in the early 2000s, the adoption of CAR therapy has been slow. What is stopping the adoption of CAR therapy, and what can we do to improve this technology? The concept of CAR therapy, more specifically CAR T therapy, seems quite simple. Design a synthetic receptor that can bind to cancer antigens, then add in the T cell's natural signaling mechanisms. That way, when a synthetic receptor binds an antigen, it can in turn activate the T cell. CAR T cells are very effective at their jobs. In some early trials, all of the patients achieved remission after CAR T therapy. However, this efficacy comes at a great cost. When CAR T cells become activated, they tend to hyperproliferate and secrete large amounts of inflammatory cytokines. These cytokines can trigger other immune cells, such as macrophages, to secrete even more cytokines. Before long, the body will become saturated with cytokines such as IL-1 and IL-6, resulting in symptoms such as fatigue, nausea, renal failure, liver failure, heart failure, respiratory failure, and death. This uncontrolled release of cytokines is known as cytokine release syndrome, or CRS. In early CAR T trials, CRS occurred in over 90% of patients. Some CAR T cells may also cross the blood-brain barrier and secrete cytokines into the central nervous system. Many of these cytokines, such as IL-1, can trigger inflammatory reactions in glial cells, resulting in neurotoxicities. These side effects, in addition to graft versus host disease and on-target off-tumor effects, is one of the major barriers to CAR T adoption, in addition to cost. To counter these side effects, researchers have developed a variety of techniques to control the activity of CAR T cells. Let's take a look at three of the most interesting approaches with the most promise. The first approach is simple: administer immunosuppressive factors such as corticosteroids during CAR T treatment. Corticosteroids reduce the inflammatory reaction caused by CAR T cells, but it may also reduce the efficacy of CAR T treatment. For this reason, interleukin receptor antagonists are more commonly used with CAR T therapy. They block cytokine receptors to help prevent cytokines from triggering inflammatory reactions, while allowing CAR T cells to maintain their efficacy. The second approach involves inhibitory CARs, or iCARs. iCARs are synthesized alongside regular CAR receptors, but instead of activating T cells, iCARs inhibit T cell function. iCARs can be activated using a molecule found on healthy cells, or an exogenous molecule that can be administered in the event of an adverse reaction. Think of iCARs as an off switch for CAR T cells. There are also systems that use other receptors, such as inducible caspases, to trigger CAR T apoptosis upon binding an exogenous molecule. The last approach involves synthetic adapter molecules. An adapter CAR can only recognize the adapter molecule, which is not found in normal tissue. The adapter bridges the link between cancer antigens and adapter CARs. That way, CAR T cells are not active without the adapter. This allows doctors to control the activity of CAR T cells by altering the concentration of adapter molecules in the body, or to stop CAR T activity by not administering the adapter molecule. That is the end of our presentation. Actually, there's one last approach. Use a different immune cell. In T cells, the T cell receptor, or TCR, enforces tolerance of healthy tissue. CAR T bypasses the TCR, which causes side effects due to on-target and off-tumor effects. Other immune cells, such as NK cells, may be more suitable for CAR therapy, as they carry natural inhibitory receptors that prevent them from attacking healthy tissue even when CAR is activated. CAR-NK therapy has its own mountain of problems, but that is out of the scope for this video. No matter which approach wins out in the end, one thing is clear: chimeric antigen receptors will play a huge role in cancer immunotherapy in the very near future.